Okay, let's dive into a clinical scenario that, well, it comes up all the time. Anyone in an ER, primary care office, an OB unit, they see this regularly.
Constantly.
And it's an area that carries just immense weight. You're balancing this really high urgency with, a very high frequency. We're talking about navigating the clinical approach to first trimester bleeding.
This is truly a cornerstone of high-stakes, rapid clinical assessment. We're focusing on first trimester bleeding, or FTB, which has a pretty rigorous clinical
Oh,
definition.
right.
It's basically any vaginal or uterine bleeding that happens from the first day of a patient's last menstrual period all the way up to 13 weeks and 6 days gestation.
So the whole first trimester.
The entire first trimester. And that broad definition covers, everything from something that's just a simple annoyance to a full-blown surgical emergency.
That window is exactly why the diagnostic path is so complex. Our sources give us this really detailed step-by-step clinical algorithm, and our mission today is to sort of map that out for you, make it a functional, memorable roadmap. The absolute top priority has to be spotting those rare, potentially lethal situations and separating them out from the much more common stable diagnoses.
And the key is timely evaluation. When you're dealing with hemorrhage and obstetrics, any delay can be, it can be catastrophic. We have to, right off the bat, recognize the highest stakes risk.
Okay, so what's number one? The diagnosis we have to exclude first.
Without question, across all our sources, it is an ectopic pregnancy.
Why is that the five-alarm fire? We all know it's dangerous, but what's the specific catastrophic risk that puts it at the absolute top of the list?
It's the risk of it progressing to a tubal rupture and then a massive intraperitoneal hemorrhage. The danger is really just anatomy.
The fallopian tube just can't handle it.
It's not designed to house a growing pregnancy. As the embryo grows, it erodes the blood vessels around it. When that tube ruptures, the blood loss into the abdomen can be incredibly rapid and it can be concealed.
So you might not even see a lot of external bleeding.
Exactly. And that leads very quickly to hypovolemic shock. That's a situation that needs immediate surgery and resuscitation.
And that urgency, that threat, really drives the entire flow of the whole algorithm.
It does.
So while we're focused on ruling out that life threat, we also have to, acknowledge the much broader scope of the problem.
The sources break FTB down into 6 major categories. Can we just list those foundational categories?
Of course, and these 6 categories are sort of the destinations on our diagnostic map. As we go through the workup, we're trying to figure out which bucket the patient falls into.
Okay.
So they are 1, genital tract pathology. That's bleeding from outside the uterus or the pregnancy itself.
Like a polyp or something.
Exactly. 2 is implantation bleeding. This is physiologic, totally normal bleeding when the embryo burrows in. 3 is spontaneous abortion, which is a huge spectrum, inevitable, threatened, incomplete, all of those.
4 is pregnancy of unknown location, or PUOL. That's when we know they're pregnant from labs, but we can't see it on imaging. 5 is ectopic pregnancy, implantation outside the uterus. And 6 is molar pregnancy, which is an abnormal placental development.
Okay, so that list of 6 really shows the scope here. But when a patient actually shows up, say in the emergency department, bleeding, the clinician doesn't start with that list.
Yeah, not at all.
They start with that one critical first assessment. Stable versus unstable.
That decision point is absolutely paramount. It comes before anything else. The first non-negotiable step for any patient with FTB is a systematic CABCDE assessment.
And that's a standardized approach, right, to stop you from getting tunnel vision on the symptoms when the patient is actually crashing.
Precisely. It prevents you from getting distracted.
So let's break down the CABCDE assessment. This isn't just a checklist for our listeners. It's a prioritization scheme. How does it apply specifically here?
It stands for circulation, airway, breathing, disability, which is neurostatus, and exposure. In the context of FTB, circulation, the C is almost always where you start.
What are you looking for?
You're looking for signs of shock, hypotension, so low blood pressure, tachycardia, a fast heart rate, pallor, cold skin, altered mental status. If that C is unstable, you stop everything else. You stop the diagnostic workup and you start resuscitation, period.
And the sources link 2 specific diagnoses to that immediate instability. Those are our urgent targets.
That's right. The 2 big ones causing rapid instability are a ruptured ectopic pregnancy, which is that internal bleeding we talked about, and sometimes a massive incomplete abortion, which causes heavy acute external bleeding.
So if the patient is unstable, you're basically treating presumed shock from volume loss.
You are.
So instability is confirmed. Walk us through the immediate steps. We're in pure resuscitation mode now.
It's immediate, it's aggressive, and you're doing things in parallel. Step 1 is stabilize the airway and breathing. Maybe start high-flow oxygen. If they're deteriorating fast or their neurostatus is poor, you might consider intubation right away.
Okay.
Crucially, you need immediate large-bore IV access. 2 lines, ideally, so you can push fluids and blood products fast. You get a type and cross-match right away for packed red blood cells, and if things are really dire, you might even start uncross-matched blood.
Wow.
And, of course, continuous vital signs monitoring is mandatory.
So for the unstable patient, the pathway is actually pretty short. Stabilize, resuscitate, and they're often heading straight to the operating room.
Yes. For a laparoscopy, for a ruptured ectopic, or an urgent DNC for massive hemorrhage from an abortion, the detailed diagnosis can wait until they're stable or in the OR.
But the vast majority of patients who present with FTB are hemodynamically stable.
That's right. And that's where the really complex, detailed diagnostic pathway begins.
So once stability is confirmed, we're shifting gears. We're moving from emergency resuscitation to more like methodical detective work, gathering a full data set.
Exactly. History, physical exam, labs, and imaging. This is where we gather the evidence to triage the patient into one of those 6 categories.
Let's start with the history intake essentials. What are the absolute non-negotiable pieces of information a clinician needs to get started on the right path?
Okay, first, you need to establish the estimated gestational age, usually from the first day, the last menstrual period, the LMP. But even more critically, you have to check if an intrauterine pregnancy, an IUP, has already been documented on a prior ultrasound.
Sounds like a huge fork in the road.
It's a massive branch point. If you know a normal IUP was seen 2 weeks ago, your differential completely changes. You're thinking about a spontaneous abortion, not trying to find an ectopic.
Okay, what else?
You need any previously assigned estimated due date, the EDD. Then you have to assess risk factors. Has the patient had prior tubal surgery, pelvic inflammatory disease, and most importantly, have they had a prior ectopic pregnancy? That raises your suspicion immediately.
It sounds like the timeline and what was known before this bleeding started is maybe more important than the bleeding itself.
In many ways, yes. Then, of course, you characterize the current symptoms, the bleeding itself, when did it start, how much is there, are they spotting or soaking a pad an hour, and is there pain, abdominal or pelvic pain, and where is it located?
And finally, that one anecdotal detail that can really point you towards an abortion status.
Right. You have to ask specifically if they've passed any large blood clots or tissue. If the patient says yes, that really helps you differentiate between a threatened, an incomplete, or a complete abortion later on. It really directs your physical exam.
Okay, let's move to that physical exam. It's a multi-step process. Where do you start?
You start with the abdominal assessment. This is key for ruling out peritoneal irritation. You palpate the whole abdomen, checking for tenderness, rigidity, or, critically, those peritoneal signs like rebound pain and guarding.
And finding those, even in a stable patient, is a big deal.
It's a huge alarm bell. It raises the possibility of occult or hidden internal bleeding.
After the abdomen, you move to the speculum exam. What are the goals there?
The speculum exam is diagnostic. First, you're looking for genital tract pathology. You're trying to see the source and quantity of the bleeding. Is it coming from the cervical os, the opening of the cervix, or is there a cut, a lesion on the vagina or the cervix itself?
And you're also looking for...
You're also looking for products of conception. Is there any tissue visible in the vagina or stuck in the cervical canal?
And then comes the internal assessment, the bimanual exam.
Right. The bimanual exam lets you feel the internal structures. You're assessing the uterine size and tenderness. Is the uterus tender? Is it the right size for how far along they should be? You're also checking for any adnexal tenderness or masses.
Which would point towards an ectopic.
Strongly suggest it, yes. And most critically, you check for dilation of the internal cervical os. If that os is open, it tells you the process of expulsion is underway. You're looking at an inevitable or incomplete abortion.
And if the patient actually brought in tissue that they passed?
You have to examine it. The sources are very clear on this. You look at it closely, trying to find a clear gestational sac or any placental villi. Finding those structures confirms you're dealing with the loss of an intrauterine pregnancy, which pretty much rules out an ectopic.
Okay, so that detailed physical exam leads us right into the baseline labs and imaging. What are the essential first tests?
First, a quantitative beta HCG level, the beta human chorionic gonadotropin. This baseline level is non-negotiable.
And that helps with location, viability, follow-up.
Everything. Second, a type and screen and their RH status.
Mhm.
This is paramount. If a patient with bleeding is RH negative, you have to immediately consider giving them ROGAM to prevent RH alloimmunization. That's a serious risk for future pregnancies.
Got it. And third,
Third, a complete blood count, a CBC. You check their baseline hemoglobin to see if they're anemic from acute or chronic blood loss.
and finally, the cornerstone imaging modality, the one that really makes or breaks the diagnostic pathway.
The transvaginal ultrasound, or TVUS. It is the absolute cornerstone of the stable FTB workup. The TVUS evaluates two things that dictate the rest of the algorithm. The location of the pregnancy, is it intrauterine, extrauterine, or can we not find it? And its viability, meaning is there fetal cardiac activity present or absent?
And every single step after this hinges on those TVUS findings.
Every single.
Okay, so we've established stability, we've done the initial workup. Now we're using those TVUS results to start mapping out the diagnoses. Let's begin with the highest risk scenario, where the ultrasound suggests there is no intrauterine pregnancy.
Right. When the TVUS is done and you see an empty uterus but you have a positive HCG, well, your clinical suspicion for an ectopic pregnancy just skyrockets.
So when the ultrasound can't find an IUP, what are the specific ultrasound clues that point a clinician towards an ectopic?
When the IUP is absent, the sonographer is looking very closely at the adnexa, the area around the fallopian tubes and ovaries. The most definitive finding, though it's actually less common to see, is a visible gestational sac with a yolk sac or an embryo located outside the uterus.
And what's the more common finding?
More often, what you see is an adnexal mass. It might have a hypoechoic, sort of fluid-filled area inside it. And importantly, this mass has to be clearly separate and distinct from the ovary itself.
And the patient's history often backs this up, right? What's the classic presentation beyond just the bleeding?
The classic triad is amenorrhea, meaning a missed period, vaginal bleeding, which is often just light intermittent spotting, and unilateral abdominal pain on one side.
But it's not always that clean, is it?
No, not at all. We have to remember that only about half of patients present with that full triad. The pain can range from just mild discomfort to really severe localized agony.
And those risk factors we mentioned earlier, the signs of pre-existing tubal damage, they can really increase your pretest probability.
Oh, absolutely. A history of STIs, especially chlamydia, which can cause tubal scarring, or prior ectopic pregnancy, previous pelvic surgeries. All of those are significant risk factors that make it more likely for the fertilized egg to get stuck on its way to the uterus.
Let's talk about that specific clinical pearl for a ruptured ectopic. It's an amazing example of referred pain.
It is a hallmark sign that you just cannot miss. The onset of shoulder pain in a patient with FTB and abdominal pain. That indicates a ruptured ectopic.
And the mechanism behind that is?
It's visceral. When the fallopian tube ruptures, blood fills the abdominal cavity and irritates the diaphragm. The diaphragm is innervated by the phrenic nerve, which originates up in the cervical spine C3 to C5, and it shares nerve roots with sensation from the shoulder.
So the brain misinterprets the signal.
It does. The patient perceives the irritation from their diaphragm as pain in their shoulder. It is an immediate signal of an internal crisis.
And for a stable patient with an unruptured ectopic, what would the exam findings be?
Primarily adnexal tenderness. On the bimanual exam, when you palpate that adnexal area, the patient will often have significant pain. Sometimes you can feel a palpable adnexal mass. The labs might show a mild drop in hemoglobin from chronic spotting, or they could be completely normal.
Let's shift to another unique, urgent diagnosis where the ultrasound is key. Molar pregnancy, or gestational trophoblastic disease. This is one of the most visually and biochemically distinct diagnoses in the first trimester.
It's totally unique. It's caused by an abnormal proliferation of the trophoblast, the tissue that would normally become the placenta. The sources all describe this very specific ultrasound finding as a snowstorm appearance.
The snowstorm.
Yeah. It looks like a heterogeneous intrauterine mass that's filled with these diffuse, tiny anechoic or fluid-filled spaces. Visually, it can look like a cluster of small cysts or a bunch of grapes. And crucially, if you use Doppler ultrasound, you'll see high peripheral vascularity because this tissue is growing so rapidly.
And that structural abnormality dictates the patient's symptoms. The hormonal output is just off the charts.
That's exactly right. Because this abnormal tissue produces massive amounts of HCG, patients often have these exaggerated pregnancy symptoms. Severe abdominal bloating, and maybe the most classic sign, intense, unrelenting nausea and vomiting, hyperemesis gravidarum.
And the bleeding.
They might have light or heavy vaginal bleeding, and sometimes they even pass tissue that looks like those little vesicles, the grape-like structures.
And we have to remember the risk factors here. This is rare, but it can have historical roots.
It can. A history of a prior molar pregnancy significantly increases the risk of it happening again. And in terms of the exam and labs, that high hormonal drive is key. The physical exam might show that the uterus is way larger than you'd expect for the gestational age.
Because of all that extra tissue growth.
Right. And the labs have to confirm that hormonal excess. The quantitative HCG level is typically, astronomically high for the estimated gestational age. We're talking levels that are exponentially higher than a normal pregnancy.
And there's a weird thyroid connection too, isn't there?
Yes. Because HCG has some structural similarities to TSH, the thyroid-stimulating hormone, this massive surge of HCG can sometimes stimulate the thyroid gland, leading to abnormal thyroid function tests and even symptoms of hyperthyroidism.
Okay, let's pivot now to the most common pathway. The stable patient where the TVUS confirms the best-case scenario, the documented intrauterine pregnancy. The sac, the yolk sac, the embryo. It's all correctly located inside the uterus.
Confirming that IUP is a huge relief. It essentially eliminates the threat of a non-visualized ectopic. So the next and most critical assessment becomes viability. Is there fetal cardiac activity?
So let's take that first branch. Cardiac activity is present. The pregnancy is currently viable. The diagnosis now seems to hinge on two things: the state of the cervix and whether you can find a non-pregnancy source for the bleeding.
Exactly. This is the most common diagnostic finding in stable FTB. If cardiac activity is present etiology, the cervix is closed with no visible products of conception, your differential narrows down significantly.
So let's isolate general tract pathology first. This is a non-obstetric cause of bleeding. How do you definitively diagnose that?
It's diagnosed purely by visual inspection during the sterile speculum exam. The clinician actually sees a clear source of bleeding that is coming from somewhere other than the cervical os. Common examples are cervical polyps, cervicitis, which is inflammation of the cervix, or simple trauma like a vaginal laceration. If you find a clear lesion and the IUP is viable, you shift focus to treating that specific problem.
And if you don't find a clear external lesion, then we're left with threatened abortion and implantation bleeding. These seem like they'd be hard to tell apart just based on symptoms.
They are. Implantation bleeding is really defined by its timing. It's usually light spotting that happens about 10 to 14 days after fertilization, so right around the time of the missed period. It's very light and it stops on its own.
And a threatened abortion.
A threatened abortion is really the umbrella term we use for any bleeding light or heavy.
Yeah.
That happens during the first trimester when the pregnancy is still viable and the cervix is still closed.
And this is where we find that very common structural cause for a threatened abortion, the subchorionic hematoma.
Yes, the subchorionic hemorrhage or hematoma is probably the most common reason for bleeding in a viable first trimester pregnancy. It's just a collection of blood that forms between the chorion, which is the outer membrane of the gestational sac, and the inner wall of the uterus. A small partial detachment.
And what does that look like on the ultrasound?
It shows up on the TVUS as a hypoechoic or dark crescent-shaped area right next to the gestational sac in that subchorionic space. And while very large hematomas are linked with a higher risk of miscarriage, the key is that if cardiac activity is present, the diagnosis is still a threatened abortion. Management is supportive. It just gives us a structural explanation for the symptom.
Okay, but what if you have a viable pregnancy? You see a heartbeat, but the physical exam reveals that the internal cervical us is open.
That finding changes everything, instantly. That defines an inevitable abortion. If fetal cardiac activity is present, but the cervix is dilated, the process is considered irreversible.
So the loss is unavoidable.
It is. Because the structure designed to hold the pregnancy in the cervix has failed, even if the embryo itself is still showing signs of life. The moment that cervix opens, viability becomes a secondary concern because the body has committed to expulsion.
Management then just shifts to anticipating the miscarriage.
Exactly, preparing for the expulsion of tissue.
All right, now we enter the difficult spectrum. The TVUS confirms an IUP, but cardiac activity is absent. The diagnosis is now some form of spontaneous abortion, and the classification here relies heavily on these objective, standardized measurements.
Right. And we'll start with the scenario of a non-viable pregnancy that hasn't expelled the tissue yet. So a closed cervix and no products are visualized.
The crucial thing here is to avoid a premature diagnosis, right?
Absolutely. You have to rely on evidence-based metrics, otherwise you risk diagnosing a miscarriage when the pregnancy is just much, much earlier than you thought.
Okay, so the listener needs to really grasp these key metrics. These are the objective criteria that move the diagnosis from uncertain to confirmed non-viable.
They are absolutely critical. The diagnosis of a missed abortion, meaning the pregnancy has failed but is still retained, is made if the mean gestational sac diameter is greater than or equal to 25 millimeters and you don't see an embryo.
25 millimeters.
Or if the crown rump length, the CRL of the embryo, is greater than or equal to 7 millimeters and there's no cardiac activity detected.
7 millimeters, so 25 and 7.
Those are the threshold numbers. They were established through huge studies to ensure 100% specificity. If the structure is that large and there's no cardiac activity, you know it has failed.
So let's talk about the flip side. What if those measurements aren't met? The embryo is smaller than 7 millimeters or the sac is smaller than 25.
Then the diagnosis is a pregnancy of uncertain viability, or POUV. This is a crucial interim diagnosis. It means we cannot confirm failure yet, even though we don't see a heartbeat, because the structure is too small to definitively rule out the possibility of a misdated pregnancy or just delayed visualization.
So you have to wait.
You have to schedule follow-up. A repeat TVUS in 7 to 14 days, repeat HCG levels to see if it's grown normally or if it now meets those definitive failure criteria.
So POUV basically prevents a clinician from making a rash decision when there might still be a chance.
That is the central ethical and clinical purpose of those specific millimeter measurements. They are the objective standards that confirm loss.
Okay, now let's move to the other classification for absent cardiac activity. The cervix is open, and you can see or feel products of conception.
This is the straightforward definition of an incomplete abortion. It's when the cervix is open and some, but not all, of the products of conception are visible in the cervical canal or have been partially expelled.
And clinically, what does that patient look like?
They typically present with heavy, ongoing bleeding, significant abdominal cramping, and often they'll tell you they've already passed some tissue. The physical exam and the ultrasound then confirm there's still retained tissue and the os is open. The body is sort of stuck in the middle of the process.
And that's why the bleeding and cramping is so bad.
Exactly. Management here is all about safely and definitively completing that process of expulsion.
Okay, we now have to address the most challenging scenarios for management. The ones where the ultrasound is inconclusive about the location. These diagnoses seem to rely heavily on combining current findings with historical data and biochemical trends.
They do. This is where it gets tricky.
Let's talk about the scenario where a patient comes in with bleeding and they tell you they had a prior normal ultrasound confirming an IUP. But the current TVUS shows an empty uterus.
Yeah.
The embryo is gone. The question is, what's left?
Right. If you know a previously documented IUP is no longer there, you know the patient has had a miscarriage. Your differential narrows down to just two things, an incomplete or a complete abortion. It's just a matter of assessing how complete the expulsion was.
So how do you differentiate between an incomplete and a complete abortion in that case?
It comes down to the clinical picture and the ultrasound confirmation. An incomplete abortion will still show evidence of retained tissue in the uterus on the ultrasound, and that's coupled with ongoing heavy vaginal bleeding and cramping. The cervix might still be open.
And a complete abortion is defined by resolution, a clean slate.
Exactly. The patient will usually report that the heavy bleeding has significantly resolved, or they're just spotting now and the cramping has stopped or is much better. And critically, the ultrasound has to show an empty uterine cavity. No products of conception noted on the pelvic exam or the TVUS. The cervix might have closed back up.
So the history of a confirmed IUP plus an empty uterus and falling HCG levels confirms it's all passed.
That confirms complete expulsion.
This brings us to the diagnostic tightrope walk. Pregnancy of unknown location, or PUOL. This is when the ultrasound is genuinely inconclusive and you have no prior history to guide you.
PUOL is the diagnosis you apply when the HCG is positive, but you see absolutely no pregnancy, not intrauterine, not extradent on the ultrasound. And crucially, there's no previously documented IUP.
So you know they're pregnant. You just can't find it.
Exactly. We know they're pregnant, but we can't map it.
That sounds inherently unstable, yet the diagnosis is considered transient. Help us understand that.
PUOL is a transient diagnosis. It means you can't just leave it at that indefinitely. It forces you to rely on close follow-up with serial quantitative beta HCG measurements. You're basically waiting for one of three outcomes to declare itself.
Which are?
1, A viable IUP will grow and eventually become visible in the uterus. 2. A complete abortion will occur and the HCG levels will drop rapidly to 0. Or 3. An ectopic pregnancy will grow, the HCG will rise abnormally, or an adnexal mass will finally become visible.
And the core clinical concern, the thing you're most worried about during that wait, is still that silent, growing ectopic.
It is the primary preoccupation. Estimates are that somewhere between 15% to 40% of all POL cases ultimately turn out to be ectopic pregnancies. So managing POL is fundamentally managing a high suspicion for an unruptured occult ectopic.
And you're relying on those serial HCGs to see how it's behaving.
Yes. You're watching the rate of rise, looking for that telltale, slow, abnormal rise that's so characteristic of an ectopic implantation.
This is a perfect segue into the details of those serial measurements. We've established the map. Now let's talk about the detailed clinical execution.
This is where synthesizing the sources really pays off. The decisions about intervention, whether you wait, use medicine, or do surgery, are entirely dependent on location, viability, and the patient's stability.
Let's start with the most complex follow-up, managing PUOL with serial HCGs. What are the expected dynamics and the critical thresholds?
We rely on two major tools here, the rate of HCG rise and the discriminatory zone. In a normal viable IUP, the HCG level should increase by at least 50% every 48 hours, or ideally it should double every 72 hours, especially when the initial level is low.
And if it doesn't?
If the rise is significantly slower than that, say it only goes up by 20% over 48 hours, that is highly suspicious for either an ectopic pregnancy or a non-viable IUP.
Okay, and the discriminatory zone, what is that number and why is it so important?
The discriminatory zone is the quantitative HCG level above which you should be able to see an intratartan gestational sac on a transvaginal ultrasound. The exact number can vary a bit by institution, but the consensus range is generally between 1,500 to 2,000 MIU/mL.
So if a patient's HCG level is, say, 2,500, but the TVUS shows an empty uterus, that's basically diagnostic.
It's highly suggestive of pathology outside the uterus. If the HCG is above the discriminatory zone and the uterus is empty, the probability of an ectopic is extremely high. That prompts either immediate intervention or very intensive monitoring for rupture.
And if the HCG is below that zone?
Then you manage it as PUOL and you continue serial monitoring. You expect the location will reveal itself once the HCG crosses that critical threshold.
That reliance on time and biochemistry really highlights the logistical and psychological burden on both the patient and the clinician during that waiting period.
It truly does. The patient has to be educated on all the red flag symptoms, especially severe pain or that referred shoulder pain, and they have to be highly compliant with the follow-up schedule. Missing a single serial measurement could be the difference between surveillance and an emergency rupture.
Okay, let's move to the confirmed non-viable pregnancies. So a missed abortion retained tissue, closed cervix, no heartbeat, and it meets the size criteria, or an incomplete abortion. What are the three primary management pathways?
Once you've confirmed a non-viable pregnancy with retained products, you present three options to the patient. One is expectant management, which is just watching and waiting for the body to naturally expel the tissue. 2 is medical management. This involves using medication, usually misoprostol, to induce uterine contractions and help with the expulsion. And 3 is surgical management, which is a procedure like a D&C to physically remove the tissue.
Let's look at the trade-offs there. What are the pros and cons a clinician would discuss?
Well, expectant management avoids medication and surgery, which is appealing to a lot of people. The downside is that it can take weeks. The timeline for bleeding and cramping is unpredictable, and it has the highest risk of ultimately failing and requiring surgery anyway. The emotional toll of just waiting can be really significant.
And medical management, that seems to be getting more common.
It is. Medical management is highly effective, with success rates around 80–90%. It's less invasive than surgery and much faster than waiting, usually working within 24 to 48 hours. But it is associated with significant painful cramping and heavy bleeding. You have to counsel the patient on that discomfort.
And surgery offers the quickest, most definitive resolution.
It does. Surgical management via D&C is often preferred if the patient is bleeding heavily, is hemodynamically unstable, or if they simply want the fastest resolution. It's 100% definitive, but it does carry the minor risks that come with any surgical procedure.
Okay, let's talk about managing an ectopic pregnancy. We know a ruptured one needs immediate surgery. But what about a stable patient with a confirmed unruptured ectopic?
That's a prime candidate for non-surgical treatment. The stable, unruptured ectopic is often managed medically using methotrexate.
Which is a chemotherapy agent.
It is a highly effective one. It works by inhibiting cell division, which halts the growth of the rapidly dividing pregnancy tissue. The body then just gradually reabsorbs it.
But there must be strict criteria for who qualifies for methotrexate.
Oh, absolutely. The sources outline very strict prerequisites. The patient has to be hemodynamically stable. The ectopic mass itself needs to be relatively small, generally less than 3.5 centimeters in diameter.
Okay.
There must be no fetal cardiac activity detected within the ectopic mass. And the initial quantitative HCG level is ideally below 5,000 MIU/mL. If any of those criteria aren't met, the risk of methotrexate failure or rupture goes up, which favors surgical management.
And the follow-up for a patient on methotrexate has to be meticulous.
Meticulous is the right word. The patient gets the injection, and then we check serial HCG levels on days 4 and 7 after the injection. We expect to see the HCG level drop by a specific amount between day 4 and day 7.
And if it doesn't?
If it fails to decline, or if it rises, that indicates treatment failure, and the patient will need surgery. This follow-up continues until the HCG level falls all the way back to 0.
Let's quickly touch on the management of our two extremes, molar pregnancy and the very common threatened abortion.
Sure. For a molar pregnancy, once you've confirmed that snowstorm appearance and the high HCG, the primary treatment is prompt surgical evacuation via a suction D&C. The goal is complete removal of all that abnormal tissue to prevent it from transforming into a malignancy later on.
And the follow-up is long-term.
Very long term. They require very close surveillance with serial HCGs for months to ensure the levels go to 0 and stay there.
And for the much more common, less risky diagnosis of a threatened abortion, viable pregnancy, closed cervix.
Management there is entirely supportive and observational. Since the pregnancy is viable, you don't want to intervene. The patient is advised to rest, avoid strenuous activity, and we just monitor them clinically. Even if there's a subchorionic hematoma, it doesn't change the management. You just monitor the pregnancy and provide reassurance that viability is confirmed.
What stands out to me is how the entire system is designed to quickly differentiate between really 3 states: immediate surgical risk, safe, conservative management, or requiring time and biochemistry to clarify the diagnosis.
That is the core value of this algorithm. It imposes a framework on what can be a very chaotic clinical presentation. The initial CABCDE assessment prevents mortality, and then the use of TVUS and those specific metrics like the 7 and 25 millimeter rules or the 1500 to 2000 discriminatory zone allow for accurate risk stratification and management tailored to the exact state of the pregnancy.
This deep dive has really provided a necessary level of detail on an area that just demands precision and speed. Let's quickly synthesize the entire FTB pathway for the listener, just focusing on those key decision points.
Okay, so we covered the 6 major categories, but the pathway always begins by establishing stability with that CABCDE assessment. If they're unstable, you resuscitate. If they're stable, the TVUS is mandatory.
And the TVUS leads to the main split. Is an intrauterine pregnancy present or absent? If it's absent, your high suspicion for ectopic or molar pregnancy guides the workup, often requiring intervention if the HCG is above that discriminatory zone.
And if the IUP is present, viability is the next question. Cardiac activity present or absent? A viable pregnancy leads you to check the cervix closed means threatened. Open means inevitable.
And the non-viable pregnancy is categorized by those crucial size thresholds, the 7 millimeter crown rump length and the 25 millimeter gestational sac diameter, which definitively confirm a missed abortion and separate it from that temporary state of pregnancy of uncertain viability.
POUZ.
The power of this system is that every single branch leads to a clear management plan: supportive care, medical induction, or surgery.
And that leads us back to what is, I think, the most tense moment in the algorithm. That transient diagnosis of POL. We're relying on the patient being sent home with specific warnings, told to monitor their symptoms, and to stick to a strict schedule of follow-up labs.
So as our concluding thought, let's focus on the human element within all that scientific rigor.
Well, the clinical algorithm forces clinicians to use time as a diagnostic tool in that PULS scenario.
Yeah.
You're relying on changing HCG levels to locate the pregnancy before a catastrophe occurs.
Right.
So if an ectopic pregnancy is the single most urgent diagnosis driving this entire process, and if our definitive tools, like the early ultrasound, are temporarily inconclusive, what are the inherent challenges clinicians face? I mean, how do you effectively communicate the subtle but crucial signs of deterioration, like that unilateral pain getting worse or the onset of shoulder pain, to a patient who is, understandably, extremely anxious? How do you ensure compliance when the diagnosis itself is uncertain?
That's a great question.
This constant vigilance, managed over days, not minutes, that's really where the art of medicine intersects with the science of the algorithm.
A really compelling thought. It highlights that the algorithm is only as good as the trust and communication built between the care team and the patient. Thank you for walking us through this deep dive.
My pleasure.